Hi everyone, this is Professor Widener. This is the lecture for Chapter 2 on immunity. I don't think there could be a better time to be talking about immunity in the middle of a pandemic and what it means to be immune to something and how those different systems work. And there's a lot of talk right now about who is immune, who is not immune to COVID. So I hope as we go through this, you'll have a little bit better understanding of the system. And there is a lot of information here, but just take it one step at a time. And hopefully, as we go through the lecture, you'll recognize some points to your own clinical practice that will help you put together a few things and make it a little bit easier to understand. So the job of the immune system is pretty simple. It protects the body from different viruses, bacteria, fungi, and protozoans, and it removes damaged cells and destroys cancer cells. So the two primary functions of the immune system are to defend the body and then attack anything that doesn't belong there. If you look on table 2.1 in pages 48 to 49, and please note, please have your book with you because I'll refer to some of the diagrams in the book. But this gives you a good idea of definitions of what the different components of the immune system are. So if you can know these, it will help you put together the whole system of information. And the other thing I want to point out to you is if you look in the cells, I think that you'll see the neutrophils, basophils, eosinophils, and monocytes. Those are one that if you think of when the next time you look at a CBC differential when you're at work, you will see those are part of the differential. And we'll talk a little bit more about those, but it's a good way to immediately see it in action. So innate immunity is its immediate reaction and it's non-specific against all invaders. So it goes to work no matter what. This includes physical and chemical barriers. The largest organ we have is the skin, and it's also the biggest barrier to outside bacterias, fungi, all those things that we talked about. And the skin also has parts that have direct access to the body, such as the mouth, the lungs, and the GI and GU tracts. So those areas are open and lined by mucous membranes, and that consist of epithelial cells. And those epithelial cells are constantly turning over and preventing all those little microorganisms or invaders from getting through the barrier. So the mucous membranes provide another barrier for the body. The interesting thing is that the skin secretes an acidic substance that destroys bacteria. The stomach has hydrochloric acid, which also destroys bacteria. And your tears and saliva can contain lysome, which is an enzyme that destroys bacteria. So the body actually is pretty smart as we're learning about all these things. The inflammatory response can be acute or chronic. The acute phase happens immediately after the injury and continues until it's gone. Sometimes if the injury takes a longer time to heal or complete the healing, it will move into a chronic phase. When we have innate immunity, the vascular response to this is to dilate those blood vessels. So with dilating the blood vessels, we create the cardinal signs of injury, and these are important to remember. They include erythema or redness, edema, heat, and pain at the site. So if you just think about an injury that you've seen at work, you will see the redness, the edema, the heat, and the pain at the site, and now you'll know that that is part of the response to help heal this. So the mast cells are white blood cells or granulocytes that release several mediators like histamine that stimulate vasodilation. And after injury, all the cells have increased vasodilation and increased cellular permeability. So that increased cellular permeability allows the edema to form because the extra fluid is coming out. And it also allows for leukocytes to enter the cell to begin the process of phagocytosis, or quote unquote eating or ingesting the foreign bacteria and cellular debris. And that inflammatory response, if you look on page 51 in your book, is very simply depicted in that picture. And I really like it. I think it makes it very easy to understand. But you just remember, everything dilates, so it's easier for all these substances to come in and help out. So also with innate immunity, you have what's called interferons, and these trigger the enzymes that inhibit or stop viral replication. That means they stop the viruses from replicating or reproducing. We also have plasma protein mediators, and these are the complement system, the clotting system, and the kinase systems, and we're going to continue to talk a little bit more about those. Those are the immediate triggers. The more chronic phase can last weeks to months, and it occurs when the acute phase is ineffective. And when you think about a chronic phase, think of like tuberculosis. Tuberculosis hangs around for a long time. When it's in the chronic phase, monocytes, macrophages, and lymphocytes all infiltrate that area to try and get rid of it. But that lasts a long time, and you need medications to control that. The other thing that you don't think about is syphilis can also do the same thing to the neurological system. So because we know that, that it hangs around a long time and it often goes undetected, sometimes when older folks are having a change in mental status and we can't really explain it, syphilis is one of the things that we check for, because again, it can hang around for a long time. So when we talk about the neutrophils are, again, the white blood. They're the mature blood cells that are coming to fight the infection. But when there's an acute infection, the bands, which are the immature cells, actually outnumber the neutrophils. So again, when you're looking at that CBC and you might hear somebody talking about the bands, in initial infections, we expect the bands to be higher because that can be a symbol of an acute infection. Also during this time, the other lab work we might check to show that something or there is inflammation or an immune response going on, you would check a CRP, which we expect to be elevated, a fibrinogen level, because again, we expect that to be elevated, and the ESR, or the erythrosedimentation rate, again, we expect to be elevated. Interferons, again, building on the fact that they emit an enzyme that inhibits viral replication. Think of this as small proteins that are released from the viruses. These are basically, they do not, this protein does not protect against cells that are already infected, but it protects against other cells being developed. So as these infected cells are dying, they release this protein to basically help save the other cells. It's kind of a last attempt to save the other cells. So if you look at page 53, there is a diagram there, figure 2.2, that shows how the interferon works. You'll also see in this cascade of events about halfway down that uninvaded cells produce inactive enzymes capable of breaking down viral messenger RNA and of synthesizing protein synthesis. So when you think about the COVID vaccine, that's giving people viral messenger, the mRNA, to again help destroy the cells that are there so they can protect the other cells from with the infection obviously being COVID. So just talking a little bit more about plasma protein mediators. These are often cellular mediators, and they are released as part of the inflammatory process. This system breaks down to the complement system, and the complement system releases inactive antibodies that are activated by proteins, and these improve pathogen destruction, and they participate in the inflammatory response. So again, these guys come out and help activate the proteins that stimulate all this breaking down of the infection. In the clotting cycle, this is an inflammatory response that attracts neutrophils to the area of injury. When that happens, we have increased vascular permeability. Again, we talked about that helps with the fluids go back and forth. But what that also does is there is increased conversion of fibrinogen to fibrin, which is why we check that fibrinogen level, because it'll be elevated. Fibrin then walls off the area of which it is contained. So I want you to think about this. A good example of this is why one of the reasons why we put people on aspirin, like after they've had a stroke. We are trying to stop this attraction of the neutrophils to that area, because again, as the body sees a clot as a foreign substance, we want to stop the neutrophils from going to that area, because the more people that come kind of see what's going on at that site of the injury, the more likely you are to have a stroke. Because again, the more neutrophils we have, the more fibrinogen we have trying to come and wall that area off. But we don't want these things stopping to say hello to that blood clot. So that's one of the reasons that we give aspirin, to decrease that clotting response and inflammatory response. So for the kinin system, this activates when, again, there is an acute immune, and this is where you develop bradykinin, and that causes pain and increased vascular permeability through vasodilation, neutrophil recruitment, and there is smooth muscle contraction, and an example of that would be bronchoconstriction. So again, all these systems together are doing everything they can to try and attack the virus, clot, whatever is not supposed to be in the body. It's all seen, no matter what it is, it's all seen as a foreign substance to the body. So when we talk about adaptive immunity, there are two kinds. They include cellular immunity and humoral immunity. Cellular immunity is mediated by the T cells that are produced in the bone marrow. They release these into the bloodstream and travel to the thymus to allow them to mature. There are three kinds of T cells: the helper cells, the killer T cells, and the correct me on that, I'm sorry, there are actually two kinds of T cells, and those T cells are the killer T cells and the helper T cells. The helper T cells regulate cells that activate or call up the B cells to produce antibodies, and the killer T cells actually destroy the cells infected with the virus. And by doing that, they release the lymphokinins that degrade the cell wall. So again, they help break it down. The helper cells also secrete CD4, which is the target of the B cell production for antibodies. And if you think about the CD4, that is where the virus HIV attacks. So they're not allowed to make the helper cells. There's something also called suppressive T cells, and this is our cells that turn antibody production off. So as everything gets better, they stop making the T cells. The T cells are also responsible when someone has a hypersensitivity reaction or an allergic reaction, and for transplant reactions. When we move on to humoral immunity, this is where the B cells mature in the bone marrow and differentiate into memory cells or plasma cells, which produce immunoglobulins. And if you see, go to page 55, you'll see the different immunoglobulins, the IgG, IgM, IgA, IgE, and IgD. It's important to know what the function and the role is of all those immunoglobulins. So when someone, if you think, again, another example of this is when someone is septic, you may see that they don't produce a lot of these cells in the beginning. That's because of the infection that they have. Their bone marrow is working overtime. So because of that, there is suppression of the T cells and the B cells in the initial stages of an infection that then improve as the infection starts to get better. But sometimes when someone's really septic, you'll see that they don't have good. They just don't have good response to. Oh, just give me my screen. So when we look at humoral immunity, we also have two types. There's active acquired immunity and passive immunity. Active acquired immunity is gained when your body actually gets the antigen or the infection, and it produces the immunity against it. That is like if someone has COVID-19, there's proof that their body remembers that, so they have active acquired immunity against COVID-19. If you have passive immunity, this is when it's passed from the placenta of the mother to the fetus, and you can think of this as breastfeeding, or there is a plasma transfusion in the placenta as well. But basically, this means the antibodies are made outside of the body of another person. I'm sorry, that's a little bit choppy. It gets a little bit confusing, but hopefully you understand that. And but if you have any questions, please just let me know. Next, moving along to vaccines, they stimulate the immune system response to avoid the infection and the consequences of the disease. So if you think about this, we now have the COVID vaccine, we have the chickenpox vaccine. There's lots of vaccines that, again, because the consequences are so life-changing, that we have these vaccines to simulate the immune response. There are two different kinds of vaccines. There are live attenuated vaccines, and these are basically weakened forms of the live virus or bacteria that replicate but do not cause disease. Examples of this would be your measles, mumps, and rubella, and the varicella vaccine. And these tend to last longer than the inactive vaccines. An example of an inactive vaccine would be where they're made from parts of the virus or toxins that the virus produces. So again, you're given those and you produce immunity, but they often require boosters because they don't last as long. So if you think about that, that would be like polio or the rabies vaccine. Another kind of vaccine is a recombinant vaccine, and these are ones that are genetically engineered or altered, and they include the bacterial DNA and viral vectors that produce a response to the virus should it be entered into the system. And these would be examples of hepatitis V and HPV vaccine. We're going to talk a little bit about the hypersensitivity reactions. And when you think about these, you want to think of you're going to think about different kinds of reactions where the immune system is just kind of out of sorts. That's basically, it kind of malfunctions. So it does 4 different kinds of reactions, and we're going to talk about those 4 things. So this is usually immediate. Sometimes it is delayed, but usually the hypersensitivity reactions are immediate, and they result in destruction of healthy tissues. So a hypersensitivity type 1 reaction is when the T cells simulate the B cells to produce IgE antibodies to a specific antigen. These can be environmental. But when this happens, they bind to the mast cells, and these mast cells then become sensitive to the allergen. So when this happens, the body produces IgE instead of producing what it should produce, which is IgA, IgG, and IgM. This sudden release of the mast cells causes anaphylaxis. You can have anaphylaxis to anything should you be allergic. People have anaphylaxis to nuts, different kinds of medicines, but I think it's important when you're talking about allergies to talk about anaphylaxis and what your patients tell you, because sometimes they have a reaction to something, but it's not necessarily an allergic reaction. Sometimes it's just a side effect of something. Like people will tell you they can't take Flagyl because it makes them nauseated. Well, it does that. So that's a side effect, but not actually anaphylaxis. So if someone gets anaphylaxis, the treatment is epinephrine and antihistamines, corticosteroids, and sometimes now, especially with the nut allergies, they can use desensitizing injections. But either way, the whole goal of all those is to suppress the inflammatory response to whatever the trigger is. Hypersensitivity 2 reactions involve IgG and IgM, where they bind to the individual's own specific or tissue antigens, activating the complement system. The result of activating the complement system is that there is destruction or malfunction of the cells. So what you want, when you think about this one, think about transfusion reactions. So the first thing we do to prevent this is to make sure we have compatible blood. So sometimes when you'll hear that blood is taking a longer time because they have the right type of blood, but they have competing antibodies, this is why we also now check antibodies to prevent this hyper 2 sensitivity reaction, because the body will see those antibodies as foreign, that they should not be there. So obviously, if you have a transfusion reaction, you're going to stop the blood right away, but the treatment would be to ensure that the blood is compatible. And if it absolutely has to be given, you could give them corticosteroids to suppress the immune response. The other thing is that sometimes when people are pregnant, you might hear of a mom getting RhoGAM, but this prevents the maternal antibody development to the baby's blood, should there be positive or negative. Sometimes they're positive or negative with differences. So a type 3 hypersensitivity reaction is when the antigen-antibody complex is not cleared well, and it accelerates in tissues and accumulates, and it's not specifically targeted. So these antibody-antigen complexes are just kind of hanging out there, and they tend to accumulate, and they tend to accumulate in joints, skin, and blood vessels. So this is how we get autoimmune diseases. And you could think of examples of this would be lupus. So it goes through periods where it's in remission, and sometimes it is exacerbated and sometimes it's not. And treatment of this is more disease specific. Type 2, type 4 hypersensitivity reactions are where there is delayed processing of the antigens by the macrophages. These reactions cause severe tissue injury and fibrosis. An example of this would be where there is a transplant reaction. This is also how you get poison ivy. And this is also when you get TB testing and you'll see if it's positive, you get the redness in the reaction. This is a type 4 hypersensitivity reaction. And again, the treatment is disease specific. We're going to talk a little bit now about alloimmunity. And allergenic means that the tissue is used from the same species and it is similar, but not identical. So there are 4 types of tissue transplants, and allergenic would be the first one. The second one would be synergic, which is where they use the same tissue from an identical twin of the host. Autologous is where they have the tissue comes from the same host and the same donor. So an example of this would be where someone donates blood ahead of surgery where they might need the blood, so they have their own blood to use. And xenergic is where there is tissue from other species. And an example of this would be when they implant a pig heart valve on diseased human valves. It is essential to have a close tissue match as possible to prevent rejections. And should there be rejections, treatment is really the key. Prevention is really the key treatment. So in organ transplants, the immune system of the host targets the major histocompatibility complex of the donor surfaces. So to stop the immune system triggering, we put these people on anti-rejection medications. We ensure that it's an exact tissue match. And if we do notice any type of rejection symptoms, we increase the medicines to prevent the rejection. But again, when you have an organ transplant, if you need to have one, that's a chance that you might have to take. Autoimmunity is when the body fails to identify self-antigen as foreign antigens. So this is where basically the body almost kind of is trying to destroy itself. The mechanisms for self-regulating are destroyed and it causes an immune response. There becomes problems with tolerance, sequestration, and the regulatory mechanisms of the immune response, but it is not exactly clear why this all happens. They think that it possibly could be from viral exposure, medicine, or possible environmental triggers. They are seen more in women than men, and they also have some family tendencies, which shows that they could possibly be some genetic components. Examples of the autoimmune diseases include irritable bowel syndrome, diabetes type 1, and rheumatoid arthritis. The autoantibodies are basically the methods of attack, and the autoantibodies can make antigens into macrophages, which basically these antigen create macrophages that's eating on itself. And the example of this would be a hemolytic reaction, or where someone has a blood transfusion reaction. Basically, the body is attacking itself. These can affect any tissue, organ, or system, and they often, again, have periods of exacerbation. And the challenge is with diagnostic procedures is that there's not one specific blood test that's going to tell you exactly what this is. So basically, when you're diagnosing autoimmune diseases, it's a disease of exclusion. So you exclude all the other things it could be, and then you're kind of left with these autoimmune diseases. So part of the problem is, like, if you check a rheumatoid factor on someone and it's elevated, elevated rheumatoid factor can also be seen in myasthenia gravis. So it really is a diagnosis of exclusion, along with some blood work that also helps with it. And again, the treatment is very specific. So we're going to talk about a couple of the specific diseases now. Oh, sorry about that. So we're going to talk about systemic lupus erythematous, which is also one of the topics of our discussion board this week. But this is a chronic inflammatory autoimmune disease, and it can affect any of the connective tissue. Again, it occurs more frequently in women than in men. And in this, the B cells are activated, and the autoantibodies will bind to the autoantigen and form immune complexes that fight the bodies of their own tissue. So again, it's trying to destroy the body, trying to destroy its own tissue. There are some common clinical manifestations that happen in over 35% of the cases. There are some listed there, but more specifically, these patients may have fatigue, fever, and polyarthritis. They can also have glomerulonephritis. And one question that is always on every test and boards is that they get a butterfly rash. So that means that they have redness on their cheeks and over their nose that kind of looks like a butterfly. So know those symptoms as the primary ones, because they're frequently asked questions on test and board exams. So diagnosis can be challenging, but again, there are criteria that can be used. And if you look on page 65, there is a list of the clinical criteria to diagnose lupus. There can be varied clinical manifestations based on the age. The main thing we do for this is we start with NSAIDs to reduce the pain. It's really symptom management. But the other thing is that if they're in an exacerbation, they can use steroids because they're more potent to decrease the inflammation, but they also have more side effects like elevation of blood sugar. The other thing that we encourage for these folks is stress reduction, exercise, sleep, and a good diet. The other thing, if they're having a very severe reaction, is that you could do something called plasmapheresis, which is basically where you get hooked up, kind of like a dialysis machine, but your blood cycles through there and it removes the antibodies from the system to suppress the immunity. That would be a very extreme case, but again, it's just one thing that could happen to be aware of. So when someone has immunodeficiency, they have increased susceptibility of infections. Primary immunity means that there's a defect with the immune system, and secondary immunity means that there's underlying disease factor or something that is suppressing the immune system. In primary defect, it is usually caused by a developmental delay or congenital abnormality. And in the secondary delay, it is often caused by infections, malnutrition, drug therapy, stress, or possibly a history of a splenectomy. So again, this is where initially, when you have a severe infection, from sepsis, you may see that the body is not responding in the same way. You may have high bands, but the white blood cell count might actually be low. That's because for the initial part of the infection, they are immunosuppressed. And then as they get a little further down the road, about 12 to 24 hours, you can see an increase in their immune system function. The most common reasons for this are viral infections, and the other common reasons are steroids and chemotherapy. Primary immunodeficiency, there's over 350 different disorders that can cause it. You do not need to know those disorders, just know that it is a defect in the immune system, and they have defective receptor cells, defective complement system, and a adaptive system that just doesn't adapt, so it's deficient and ineffective. The antibodies are deficient, so the B cells are deficient. There is a IgA deficiency as well, and the T cells have defects. Clinical manifestations of this are usually generally a severe infection that requires hospitalization and IV antibiotics. It can include a persistent underlying infection, and it also can be seen when you are infected with an uncommon organism. Sometimes the infections are recurrent, where it's the same organism that keeps coming back and is only receptive to antibiotics. It is usually diagnosed early in newborns or infancy, and it is because they are seen as life-threatening infections. These infants have severe T-cell immunity. The treatment is basically treat the infection that is there, but vaccines can also help, and they can also consider immunoglobulin replacement therapy and stem cell transplants. We're going to talk a little bit now about HIV and AIDS. This is back in 1995 when it kind of came onto the scene. It was the #1 cause of death for people between the ages of 25 to 44. Now, with the improvements we've made in preventing and treating it, it's now down to the 7th leading cause of death between that age group. It still mostly affects bisexual people, gay people, or men having sex with men. It certainly can affect other people too, but is still most common in that population. The transmission happens with direct contact to the infected blood or the body's mucous membranes. So there can be secretion like rectal vaginal secretions or breast milk. The other way it can be transferred is through injection of drugs. We've now seen that on the decline as well. And it's important to know here too that a needle stick injury is a minimal exposure that you would likely have transmission where you get HIV, but it is treated pretty aggressively to stop the conversion until you know for sure. HIV can also be transferred from the mother to the child, but that can be reduced if the mother's on retroviral medications, and it also can be reduced if the mother has a C-section, because again, the child is not exposed to the vaginal wall tissue during delivery. We're going to go over the HIV life cycle next. It's on page 69 in your book, and it's the main thing here is to know the different spots where you see the stop sign, because those are the different drugs that we have available to stop the HIV in its life cycle. So in the first step, which is called binding, the HIV binds or attaches itself to the receptors on the cells of the CD4 cell. The next step is where the HIV envelope and the CD4 cell membrane fuse together, which allow HIV to enter the CD4 cell. Once it enters the cell is when reverse transcription happens, and there the HIV releases and use reverse transcription, an HIV enzyme, to convert its genetic material from HIV RNA into HIV DNA. This conversion allows HIV to enter the CD4 cell nucleus and, combined with the cell's genetic material, produce cellular DNA. The next step is integration. When inside the CD4 cell nucleus, HIV releases integrase, which is an HIV enzyme. The HIV uses this to insert viral DNA into the DNA of the CD4 cell or the healthy cell. Once there, replication happens. And again, once integrated into the CD4 cell DNA, HIV begins to use its machinery of the CD4 cell to make long chains of HIV proteins. These protein chains are the building blocks for more HIV. As those chains are increased in number, the new HIV proteins and HIV RNA move to the surface of the cell and assemble into immature HIV. And finally, the last step is called budding, and that is where newly formed, immature, non-infectious HIV pushes itself out of the host CD4 cell. The new HIV releases protease, an HIV enzyme that breaks down the long protein chains into an immature virus, creating a mature virus. So it just keeps replicating itself. You don't need to know the specific drugs at this point, but just have the general idea that the CD4 cells enter with the HIV. So that diagram on page 69 is really helpful to understand that. The clinical manifestations. HIV is a tricky disease because usually through the first part of it, you have no idea that you have it. You may have some subtle symptoms where you have like a little flu type symptom or a little headache or maybe some mild flu symptoms, but then generally they go away. But during that stage, generally you can still transmit HIV, but you don't know you have it. So in the first stage, or the acute retroviral syndrome, which is the stage, you might find that you see patients with demarcated ulcers in their mouth, their esophagus, on their penis or around their anus, and these develop usually 4 to 6 weeks post-infection when they have a high viral load, the CD4 count is down, and there's a high transmission potential. So that's the dangerous thing about HIV. You may be transmitting it and have a high transmission and not even know that you have it. When it enters the clinical latency or chronic HIV infection, you still may have no symptoms, and it can be this way for up to 10 years, depending on your health and your health behaviors. Once it actually reaches the late stage of AIDS, that is when HIV has methodically infected and destroyed CD4 cells. As it destroys more cells, you get more severe symptoms, and they include dysarthria, weight loss, fever, cough, shortness of breath, and lymphadenopathy. AIDS is defined as a CD4 count of less than 20. And once you actually get the diagnosis, it's usually about 3 years until the time of passing away from AIDS, which is the life expectancy. we have, once you convert to AIDS, we have come so far in with our treatment of AIDS and HIV that really people can stay with be HIV positive now and live a happy, successful, long life because of the treatment of it, which is amazing. From where I remember back in the early 90s when it kind of came and kind of became better understood. So the diagnostic tests that we can use, the initial antibody tests will take about 3 weeks to be positive. The primary test that the CDC recommends is the combination antigen and antibody test, done approximately 6 weeks after the exposure. There can also be a measurement of the viral load, and that is where some of the medicines work. We want to keep the viral load down so the virus can stay in check and not multiply as fast. The other thing, when we can see people converting from HIV to AIDS, you're going to also notice that they start to develop opportunistic infections, which include CMV or cytomegalovirus. There are also two kinds of pneumonia that they become well known to. And again, this is always a test question too on the boards, but a pneumocystic, it's a JIROVICI. Javarsi, that is one of type of pneumonia, again, not common in people who don't have HIV, but common in people with it. That's why you'll see as the HIV progresses, you'll see people on opportunistic infection prevention, which includes fungal infection through diflucan, and they'll also be on a Bactrim, usually one tablet every other day to prevent against this pneumonia. You might also see in these folks a Mycomium Bactrim avium complex. So the treatment is highly effective. It's called highly active antiretroviral therapy. This is the recommended approach at this time. It includes generally 3 or more different classes. The key to this is that you have to remember to take it exactly as ordered to decrease the chance of resistance. But again, as we said, it can be used. It can be used and people can live a long, healthy life with that. It can be given as you'll see in the middle of the change a PPER. That means it can be given pre-exposure. That means when there's a high risk of developing an infection. So people can sometimes use this even as preventative to prevent an HIV infection, but they can also use it post-exposure. An example of that would be if someone has a needle stick, you would want to start the HIV treatment as soon as possible, which means anywhere between an hour to no later than 24 hours to prevent that virus from starting to replicate. This continues to be a public health issue around the world, and we need to try and increase the availability of HRT to people around the world, and just diagnosis. In some countries, that's not even a possibility. So there's a few strategies that you can use to prevent HIV, and that can be avoiding contact with other people's body fluids, avoiding activities that increase the risk of exposure to those bodily fluids, such as drug use and multiple sexual partners. Education is also important in preventing it, and the use of a condom during every sexual encounter. We can also use the medicines, again, pre-exposure and post-exposure, and also male circumcision decreases the possible transmission of HIV. So I know this has been a lot, and it's a lot to listen to. So just listen to the lecture and read through the slides a few more times in your book. I think the book really lays it out in a nice fashion. So after all this, what can we do to encourage our patients to have a healthy, strong immune system? And that means we want to develop early exposure to some antigens so our body can operate. Sometimes people don't want their kids to be exposed to things, like when you go to daycare, everybody gets sick usually the first year, but again, that also helps them build a stronger immune system by being exposed to those microbes. For today, why, and again, during COVID-19, what do? We limit the exposure to those, so we keep our units or our circles small. We use good sanitation and prevent widespread antibiotic use. There is also, again, with this early exposure to antigens, is that we over sanitize things. So really, like in our bathrooms, we should just use regular hand soap and not sanitizing soap, because again, some of those microbes help us develop a stronger immune system. So I'm sorry that that was a little choppy, but I hope it makes sense. It is a pretty complex topic, but again, important to understand. And if you have any questions, just please let me know. Thank you.